Without a free airway, the administration of a general anesthetic is impossible. Obstruction may arise at any part of the air passages, but the greatest danger and the most difficult to deal with is when obstruction occurs at the larynx itself. The popularity of endotracheal anesthesia is therefore easy to understand because its fundamental principle is absolute airway control by intubation of the larynx. Once this control is secured, the difficulties and risks of respiratory obstruction no longer arise. In operations in the region of the head and neck, the tube can be passed through the mouth or through the nose according to the site of the operation. Obviously, when no contraindication exists, the oral route is indicated for an operation on the nose, and the nasal route is used when the site of the operation is the mouth. In other operations, it is preferable to choose the oral route, as this ensures the use of a tube of optimum caliber. Here is the apparatus you will need. First, a laryngoscope. Any efficient model will do. A wide side slot and illumination from a self-contained battery are advantages. This is a U-shaped instrument, and this is the modern folding type. Two types of mouth gags, the molar type and the incisor type. Angulated forceps. These are necessary for packing the throat with gauze and also to assist nasotracheal intubation. They are so constructed that the hand holding them does not obscure the field of vision. A spray for applying a surface anesthetic to the patient's throat. A drop bottle containing an ephedrine paraffin preparation for use before nasal intubation. A lubricant for the endotracheal tubes, and a roll of gauze impregnated with liquid paraffin. You should have handy as well a roll of 1-inch adhesive plaster, and before beginning intubation, prepare a piece for the protection of the teeth during the insertion of the laryngoscope. Cut a strip about 8 inches long and fold it over to 1/3 of its length. Now for the endotracheal tubes. These are made from ordinary commercial rubber tubing, which is stored in coils, so that its natural curve is readily adaptable to the course of the air passages. This material differs from drainage tubing in being firmer in consistency and less liable to collapse on external pressure. To make an endotracheal tube is a simple matter. First, cut off a length of the tubing at an angle of about 45 degrees. This is how to measure the length of the tube. It should be twice the distance between the lobe of the ear and the ala of the nose. Now smooth the beveled edge with an emery file or a carborundum stone. When it is quite smooth, it should look like this. Thirteen sizes of endotracheal tube are available. They range from 00 to 10 McGill scale, or from 13 to 37 in the French catheter gauge. Lastly, a series of metal connections graduated to fit the different sizes of endotracheal tubes. There are two types, oral and nasal. The oral type is a wide angle which fits snugly to the chin, and it is long enough to prevent the rubber tube being bitten by the patient's teeth. This type should never be used in the nose, as it would project too far and tend to cause kinking of the rubber tube when the towels are applied. The nasal connection, on the other hand, has a sharper curve and projects as little as possible from the patient's nostrils. As soon as an operation is finished, it is important that the endotracheal tube is properly prepared for further use. First, the tube and the connection are taken apart, and the tube is then cleaned on the outside with a swab dipped in ether. Take great care that the inside of the tube is not neglected. Scrub it with a narrow test tube brush and plenty of hot water. Then look through to make sure that no mucus has been left inside. Now place the tube in the sterilizer and boil it for 2 minutes. One word of warning, however. Here is a tube that has been boiled with a metal connection attached, a thing that should never be allowed to happen. You can see that the end of the tube is now permanently stretched. It is therefore unsafe to use it. When the tubes have been boiled for 2 minutes, they are stored in a round box so that the curve is preserved. On no account should they be tightly tied in bundles, as the constriction will permanently indent them. Immediately before use, the tubes are immersed in a solution of benidite of mercury in the proportion of 1 to 1,000. See that the metal connection is properly attached before lubricating the tube. It might be disastrous if it came apart during anesthesia. Vaseline is a satisfactory lubricant, but even better is a lubricating medium which contains a surface anesthetic such as Nupercaine, because this reduces the tendency to cough when the tube is moved during light anesthesia. This is a useful formula. Lubrication serves 2 purposes. It makes intubation easier and also helps to protect the mucous membranes, which may be dry as a result of pre-medication. Before or during induction, it is a good idea to spray the patient's throat with a surface anesthetic such as 2% anaphane. This reduces the irritability of the throat reflexes and makes it unnecessary to have a deeper level of anesthesia for intubation than that required by the operation. When nasal intubation is indicated, a few drops of a paraffin ephedrine preparation such as Endrine give maximum patency and lubricate the intended course of the tube. The correct position of the head is the same for oral and nasal intubation. A pillow is placed below the occiput. In this way, the patient assumes the position of a man sniffing the air. These diagrams show the position of the head more clearly. The head is slightly extended on the atlas with the cervical vertebrae in normal relationship to the dorsal vertebrae. This is the respiratory tract. When the head is in the right position, the air passage takes a curved course from the nostril to the vocal cords. We shall apply this knowledge later to the technique of blind nasal intubation. First, anesthesia is induced to a depth sufficient to relax the mandible. For the beginner, it is a good idea to deepen the anesthesia even further and so make sure that the patient will still be deep enough during the passing of the tube. Remove the airway and place the folded piece of adhesive plaster over the edges of the upper teeth to prevent them from being damaged by the laryngoscope. The lips and teeth are separated with the fingers and the laryngoscope is passed between them along the dorsum of the tongue. From now on, the course of the laryngoscope must be followed by constantly looking through the instrument. First, let us see in this diagram which are the landmarks along the course of the laryngoscope. The first thing to be illuminated is the dorsum of the tongue. The laryngoscope is advanced along the tongue, and when it is advanced about half the distance it must eventually travel, the uvula comes into view. When it has reached 2/3 of the full distance, the epiglottis is seen. When this appears, the laryngoscope should be gently advanced and the epiglottis lifted and held by the tip of the instrument. Finally, the glottis and vocal cords come into view. So long as the glottis is open, the tube can be passed along the lumen of the laryngoscope into the larynx. The beginner will have to learn to recognize these landmarks as they appear to the anesthetist. We will now see what they look like through the laryngoscope. This is the uvula silhouetted against the wall of the pharynx. The bulb of the laryngoscope can be seen on the left. And here is a simplified drawing of this region. The epiglottis is the next landmark to look out for. This is the drawing of it, and here is the real thing, partly masked on the right by a fold of the pharyngeal wall. Next, the arytenoids and the opening of the esophagus. When the epiglottis has been lifted by the laryngoscope, the glottis can be seen. This is what it looks like when it is closed. The cords are in apposition, with the false cords also coming across. On no account should the anesthetist try to intubate when the glottis is closed, as attempts to force a passage only lead to spasm, besides damaging the mucous membranes. When the glottis is open, the cords are abducted and the tracheal rings can be seen beyond. Once this view has been obtained, the tube can be slipped through the open glottis into the trachea. Watch for these landmarks closely as you insert the laryngoscope. Once the laryngoscope has been successfully guided into position, pass the tube down. When it is in the trachea, and there should be no doubt about this when a laryngoscope has been used, the metal connection should be strapped to the patient's face by adhesive plaster. The hose from the anesthetic machine is then fixed in position. When there is any likelihood of blood reaching the larynx, it is necessary to pack the pharynx carefully. Packing is deposited in such a way as to hold the soft palate against the posterior wall of the pharynx, thereby encouraging the soft palate to fulfill one of its natural functions. This method of packing is more satisfactory than putting in packs behind the soft palate and is less likely to lead to injury. No blood can now reach the trachea, and the packing also makes sure that breathing takes place entirely through the tube. An alternative to gauze packing is the Goodell Waters inflatable cuff, fitted onto the endotracheal tube itself. The tube fits quite loosely into a test tube so long as the cuff is deflated. Air is pumped into it by a syringe attached to the supply tube. This is then clamped off. As you can see, the cuff now fits firmly against the walls of the test tube that makes a watertight packing. The cuff tube is inserted into the trachea in the same way as an ordinary endotracheal tube. The anesthetic machine is attached, and then the cuff is inflated. The pilot bulb indicates the state of inflation of the cuff. With the tube in, anesthesia can now be maintained by ordinary inhalation methods. Often the anaesthetist has to control the administration from a distance. Any efficient machine will do, and the system may be open or closed. When no machine is available, Flagg's method of attaching a length of rubber tubing to an ether can is a useful improvisation in emergencies. Successful blind intubation depends mainly on the correct position of the head. As we have already seen, the course of the air passage from nostril to glottis is curved. When a tube which has a similar curve is passed through the nose, it tends to follow this course and enter the trachea. After induction of anesthesia, the tube is passed along the floor of the nose until the breath sounds are heard at maximum intensity. The tube is then advanced during inspiration. Its presence in the trachea is indicated by full respiration taking place through the tube. Now the same process in slow motion photography. Successful blind intubation depends entirely on the sense of hearing, so the anaesthetist must listen carefully to every sound that comes through the tube. If the ear is kept close to the end, the current of air can be felt as well as heard. As long as the breath sounds increase in intensity, the tube is following the proper course towards the glottis and may be steadily advanced. But if the breath sounds diminish in intensity, the tube is no longer advancing towards the glottic opening. The tube is then withdrawn a little and rotated slightly. During the rotation, the distal end of the tube should pass over the glottic opening. The breath sounds suddenly increase. The rotary movement is arrested and the tube is slipped in. Here again, we repeat the blind intubation done at normal speed. If the tube does not go in readily by the blind method, the anaesthetist should on no account continue prodding. Inexpert intubation and the use of force instead of skill are likely to result in trauma. This is a potential disadvantage of endotracheal anesthesia, but it is avoidable. In a difficult case, the anaesthetist should resort to the laryngoscope and forceps. Pass the laryngoscope as before, and then insert through it the angulated forceps. Then it is an easy matter to pick up the end of the tube and guide it into the larynx. When the tube is in position, the metal connection is strapped to the patient's face in the usual way. Anesthesia can be maintained as before by using an anesthetic machine, or by means of an ordinary mask and ether drop bottle when the anaesthetist has free access to the patient's face. In this case, the metal connection may be discarded and the endotracheal tube is transfixed by a safety pin to prevent its disappearing down the nose. A further alternative is Flagg's method, used in the same way as with oral intubation. The throat can be packed with gauze as in oral intubation in cases where there is any chance of blood reaching the larynx. Here we see the end of a nasal operation. During the course of the operation, the pharyngeal pack has prevented blood from running down towards the glottis. When the pack is removed, suction is used to clear away any blood which may have trickled down from the nasopharynx. After this, the airway is first inserted and the endotracheal tube is then removed. It is a good practice, where possible, to retain the tube in the trachea until the cough reflex is active. Coughing is a safeguard which prevents blood and other foreign fluids from being inhaled. The main advantage of endotracheal anesthesia is absolute control of the airway. Once the tube is in the trachea, the breathing will remain free and there will be no possible danger of respiratory obstruction. This holds true irrespective of the position of the patient's head. Certain positions on the table make airway control difficult. By using an endotracheal tube, this difficulty is overcome. Once a free airway is assured, the anaesthetist and his apparatus can be completely clear of the field of operation. By watching the movements of the rebreathing bag, he can detect immediately any change in the character of the patient's breathing. By packing the patient's pharynx with gauze, he can be protected from the entry of blood into the trachea. Here is a patient being placed in the prone position for a craniotomy. Notice that the anaesthetist does not lose his hold on the tube while the patient is being moved. Also note that endotracheal anesthesia is of the greatest advantage to the surgeon in helping him to maintain strict asepsis. Not only has the method proved a benefit to the patient and the anaesthetist in the protection it affords to the airway, it has considerably increased the scope of surgery in the region of the head and neck.